Okay, it's 1:30 p.m. Good afternoon. Welcome to Preventive Medicine Grand Rounds for July 7th, 2021. I'm Mike Cherry from the Division of Scientific Education and Professional Development. The Preventive Medicine Grand Rounds is sponsored by the CDC Preventive Medicine Residency and Fellowship and the Health Resources and Services Administration Bureau of Health Workforce. The PMRF provides 12 and 24-month full-time longitudinal service learning opportunities with senior public and population health leaders to physicians, veterinarians, and nurses who have completed the EIS program or have equivalent public health experience. We use Zoom for the audio and presentation and the question box to pose questions. Note that you can pose questions via the question box at any point during the lecture, and the speakers will work on answering them at their discretion. Note your name may appear associated with the question you posed. If you do not want your name to be associated with the question, then please check the Submit Anonymously box. Continuing education credits are available for the live course for up to 1 month after the presentation date, and for the recorded version for up to 2 years from the date of the presentation through the CDC Training and Continuing Education online portal. The course code for this Grand Rounds is all capital letters CDCPMRF. If you have any questions, please contact the program at prevmed@cdc.gov. That's prevmed@cdc.gov. Please remember that the views presented by the speaker are theirs alone and do not represent CDC, the Department of Health and Human Services, or the US government. Today's Grand Rounds will be Community Water Fluoridation, History, Science, and Public Health Impact, presented by Dr. Adam Barefoot of Georgia Department of Health. The presentation will be approximately 1 hour with 30 minutes for question and answer afterwards. Please welcome our presenter, Dr. Barefoot.
Thanks, Mike. I appreciate the opportunity to be here today. As a recent graduate of the PhD program, I've had an opportunity to attend these as just a viewer for the past year, and it's been wonderful learning on a variety of topics. So I feel very privileged today to come and talk about something near and dear to my heart. And I think probably might not be something everyone thinks about, but really is an amazing public health and population-based strategy that's been very effective over the last 75 years. And that's community water fluoridation. A little bit about my background. I'm a Georgia licensed dentist. I came on about 3.5 years ago with the Georgia Department of Health as the state dental director. But prior to that, I was a dental director for a federally qualified health center in rural Georgia for about 6 years. And during which time I got my MPH while working there. And it really brought my attention to ideas of population-based health and population or community-based interventions, which aren't necessarily a big focus in the dental community. I mean, a lot of my training is very patient-centered, individual care-centered. And I'll be the first to admit, I mean, I learned that fluoride was good for teeth in dental school, but that's about where it stopped. You know, it's one of these things, and I think we can all sometimes be guilty of this, of being complacent or just kind of forgetting these wonderful public health interventions that have been developed over the years. And kind of just take them as a given. I think a lot of what's gone on, good and the challenges with, say, vaccines over the past 10 years, 20 years, 100 years, the whole history there is a strong parallel for community water fluoridation. And it got me thinking, you know, a lot of people, unfortunately, from generations that experienced life pre-vaccinations or pre-water fluoridation, are just, they're not around anymore, and hearing their side of things of when, you know, life before that. And so I think we kind of, it's almost like, you know, you lose something in stories across the generation. But I think it's important for us to all take a moment and appreciate some of these things that have been around for a long time, but kind of may have fallen to the back of our mind. Just a quick disclaimer, I have no real perceived vested interest. This presentation is no financial things to disclose, no connection to any products or corporations or pharmaceuticals or anything like that. It's kind of a standard disclaimer. My thoughts are my own and don't necessarily represent the positions of Georgia Department of Public Health. I would like to thank Dixie Ann Parker. She's on my team and I work with her every day. She's the fluoridation administrator for the Georgia State Oral Health Program. And she's probably honestly more knowledgeable than I could ever be at this stuff. She's done it for the last 10 years. She contributed a lot of the content and slides for this presentation. I'd also like to thank the CDC Division of Oral Health. They have an amazing repository, extensive resources that I borrowed from, and some of their presentations that they offer up for public use. And specifically Tracy Beamer, who is the Department of Oral Health, the Division of Oral Health's National Fluoridation Engineer, who contributed some of her expertise. I was constantly asking her questions, so thanks. Okay, so just let's start with just the obvious thing. What is fluoride? Well, the National Institutes of Health describe fluoride as a mineral. It is naturally present in many foods and available as a dietary supplement. It's the ionic form of the element fluorine, and it inhibits and reverses the initiation and progression of dental caries. And dental caries is just our fancy word in the dental community for dental decay or cavities. All means the same thing. And it stimulates new bone formation. I'm going to talk about the process in a little bit. But it's present in soil, water, plants, foods. And when I say water, I even mean oceans, rivers, lakes, and I'll talk about that in a second. But the key to this is it is natural. It is not some synthetically derived thing. It is present everywhere. It's just a matter of in what quantities. Like I said, it's occurring everywhere. If you look at surface water, like rivers and lakes, it's typically in lower concentrations, around 2 milligrams per liter. That's kind of the unit we use for this, which is also equivalent to parts per million. Groundwater wells, which are of course dug deeper, can have higher concentrations. Again, this is not community water fluoride. This is just natural occurring fluoride in the water, about 0.1 milligrams per liter to over 5 milligrams per liter. And of course, ocean water, which hopefully none of us are drinking, can be average a little higher, around 1.4. So where did this all begin? Again, we've kind of aged out of even knowing kind of where the roots of this grew from. But it all started in 1901. There was a young dentist named Frederick Decay, and he moved across the country from the East Coast over to Colorado Springs, and he had set up a practice and immediately started noticing something, that a lot of the patients there had a very dark brown stain on the teeth that he could not polish off, couldn't get off. They call it Colorado brown stain. The local dentist in the area didn't really give much credence or really care about it. They were just, this new guy coming in and saying, "This is crazy. I've never seen this." They said, "This is just what we experienced." But he did note that with his patients, it was only with lifelong residents that had the stain. It wasn't people that had moved there, transients. And he termed it mottled or mottled enamel. And he became kind of obsessed with this. He kind of dedicated his career to it. He went traveling around asking if any others had seen it. He documented it. And then in 1909, 8 years later, there's a conference in Colorado Springs where he convinces the people to organize the conference, invite G.D. Black, who was the man, the dentist of the country at the time. He's actually still today, every dentist in dental school, even today, has to memorize his name. He's the one that is like considered the father of operational dentistry. How to prep teeth, everything. His writings are still taught in schools. And so he's the dean of Northwestern Dental School at the time. And he's like, I'm skeptical of this. I am the dentist of noteworthiness in the country. I would have heard about this. It would have been in the literature. So he actually goes out there and reviews some of the documentation that Decay has. And he's astounded. He starts in researching for this. I found out he started walking around town, just finding children playing on the street. He started talking to them just so he could see their teeth as they talked. And he was amazed. He did notice this everywhere. But they did find that despite this, what looked like an obvious developmental abnormality of the teeth, it didn't lead to greater risk of dental decay, which they found very surprising. Around the same time, in 1914, the U.S. public drinking water standards were enacted. So people started thinking about safety and quality of drinking water. And this was a federal guideline, but a lot of states started adapting similar guidelines for just the state level. So Decay keeps working. G.D. Black passes away in 1915, but Decay keeps working, reaching out to their dentist. He thinks it must be something in the drinking water, something to do with wells. He's finding out other towns as far away as Italy. There was a town near Naples where they had similar findings, and they had just changed to a new water source. And all of a sudden, the brown stain of the teeth went away. And that had gone back since like Roman times and people in that small community. He also finds out that a place called Bauxite, Arkansas, which was basically a corporate town owned by the company that eventually became Alcoa, is having reported signs of this. And so he's getting together with other dentists, writing up reports. In 1930, one of the reports Decay writes winds up on the desk of H.B. Churchill, who's the head chemist of this aluminum company of America. And at the time, they had been worried that some of their products that were made of aluminum, that were used for cooking ware, pots, pans, that there was some worry that, oh, this is getting the drinking water, this is a concern. And so he was kind of the quality control guy. He was the PR guy that making sure that they're not getting caught up in this or they're not getting in trouble for this. So he said, I'm going to do my own test because I don't want this to blow back on us. And he has some new technology at the time with spectrometry and has an assistant analyze the water samples and notices there's high fluoride. And at first he's like, you did this wrong, assistant, go back and do it again. There's no way this is true. And they come back, it's high levels again. And so he reaches out to McKay and said, well, all I can tell you is it seems like fluoride is high in this water. And so McKay sends samples from Colorado and they notice a very high level of fluoride as well. Meanwhile, about a year later, Dr. Trindley Dean at the University of Pittsburgh kind of starts hearing about this. And he starts hypothesizing that this molted enamel is maybe caused from too much fluoride intake. And he renames the term dental fluorosis. So he's one of the first that starts a long line of epidemiological studies to determine the relationship, really not for the benefit so much as but understanding fluorosis when there's far higher levels than normal in water. But he is also at the same time kind of secondarily noticing that these people that are exposed to this also don't have a lot of tooth decay. And so, by 1936, he's got enough data that he says that people who drink water fluoride around, or water with fluoride concentrations around 1 part per million or 1 milligram per liter have very low chances of developing any of this cosmetic fluorosis, this Colorado brown stain. And so then he's thinking, well, those people that had that, they didn't have decay at 1 part per million, or they don't have the bad signs of it, but do they have the benefits of not having dental decay? And then after a little while, a couple of years longer, and doing a lot of other studies, he notes that there's a very strong inverse relation basically between level of fluoride in the water and dental decay in the community. So in 1939, another doctor is the first one that says maybe we should be adding fluoride to drinking water to prevent tooth decay. And it starts to grow because you have to understand that the times were different then, and this was a very serious issue. A lot of people were in dentures. A lot of people were losing teeth, by their late teens or early adulthood. And so in 1942, about 21 cities come together and Dean publishes the findings in an NIH study of over 1,700 children. And he notes that basically around 1 part per million, it's a safe level that's not causing any fluorosis, but it's having that kind of optimal level of preventing tooth decay, and that there's no really negative risk. And a lot of the kind of the metrics he used are still kind of, to some degree, included in metrics and determining ranges and rates today. And 3 years later, the very first fluoridation trial started. They basically planned to do a 15-year trial in communities where they would start adding or adjusting fluoride in the drinking water to what they thought at the time was about an optimal level, about 1 part per million. And then they would compare it to a control city nearby, similar size, that didn't have that natural fluoridation level. And so this actually happened almost simultaneously with several cities, but Grand Rapids, Michigan was the first to get it day one. I think several got it just a couple of months later, but they kind of get the credit. And they're considered to be the first U.S. city to adjust fluoride concentration. And that's what we're talking about here, adjusting fluoride to kind of an optimal level in the public drinking water in 1945. And so you did the math already in your head. That means that 2020 was the 75th anniversary of community water fluoridation in the United States. And a lot of what I've just talked about here, CDC has a great kind of timeline, and they even go into more detail. So if you want to have the full story, feel free to go to that link down there. Unfortunately, we did in the dental community still try to have a celebration, but you may remember 2020 had some other things going on. So it probably wasn't to the extent we wanted to. There was a big kind of virtual conference with the American Dental Association that we had a lot of talk about it. But of course, we all had things on our mind other than that last year. So again, think about this in context. At the time, 1945, or first half of the 20th century, you had extractions of first molars in young children that was routine. Typically, school children developed 3 or 4 new cavities each year. Full extractions, complete dentures were basically the norm. It wasn't a question of if or when, but or what wasn't a question of if, but when. Things like dowries for new brides sometimes included dentures, and sometimes high school graduates got them as a graduation gift. Things like World War II and military preparedness, which still affects us to this day. Recruits were rejected if they did not have 6 opposing teeth because they knew they couldn't necessarily get adequate nutrition. And initially, almost 40% were rejected because of dental pain. Now, after that 1945 fluoridation began in Grand Rapids and some of those other cities, we basically had about 13 to 15 years of these early trials. And what was basically noted was that these towns had 50 to 70% reduction, especially in children, and their dental decay rates. And these children, many times, were being followed up, having annual exams as part of the trials, and well documented. And one thing they noticed, there's no adverse health effects detected then or in any subsequent trials since then. So what is the kind of the definition now of fluoridation? Again, it's the precise adjustment of fluoride in drinking water to an optimal level. I mentioned that wells could be anywhere from 0.1 to 5. We currently have a target of about 0.7 parts per million. It's changed a little bit over the years. We've had ranges, we've had targets. At one point, it was a range of 0.7 to 1.2 with a target of 1. There was a period of time where they thought that maybe we should have different ranges or different targets depending where you are in the country. Maybe you're in a hotter area, you're drinking more water throughout the year. If you're in a place like Florida, then some places cold most of the year, and so maybe they should have less fluoride in the water because they're just drinking larger quantities of water. Basically, over time, we kind of arrived on this 0.7 target, but the general range is still pretty close to what it was almost 70 years ago. The current recommendation, and I got to use the right language here, the proposed operational tolerance range for optimum water fluoridation is 0.6 to 1.0 milligrams per liter, which is the same as part per million, with an actual target of 7. The reason you have a range, even though you have a target, is it's actually very difficult to hit the nail on the head right exactly at 0.7 for community water fluoridation programs. And so you try to have a tolerance range that will get the maximum benefit, but provide some flexibility. As many of you know, with CDC, whenever there's a very formal change to any kind of recommendation or numbers or values, there's a process involved. It takes several years, obviously. It has to go out for public comment. So we're still in this process. I can't speak for when that will end, but it's been going on for several years. So my hope is we are towards the back end of that, and we will have it be not just a proposed operational tolerance range, but the official range very soon. I went back and actually looked at some of the justification. This was actually taken from the Federal Registry when the public comment period was open back in 2018, and some of the justification. And they note that water plant operators and community water fluoridation programs at water plants, they tend to have a strategy to kind of minimize. They don't want to waste product. They don't want to waste things that are costing them time and resources. And so they did an asymmetrical range. They didn't just put 0.7 in the middle and say the range is 0.5 to 0.9. They aired up a little bit because we have seen that if you get up to 0.6, you have exponential benefits as far as reducing dental decay. From about 0.6 to 1, you still have a benefit increasing, but it starts leveling off. Then after 1, you really see a diminishing, a real plateauing of the benefit. So that's why they wanted to make sure we're at least kind of maximizing up that 0.6, still trying to hit 0.7, but provide some flexibility. And we know if we're capping off at 1 milligram per liter, then we really reduce the chances of any kind of negative impact like for dental fluorosis at all. Really, you have to be twice that, over 2 milligrams per liter, to really even be getting into any of that. But a lot of you may be thinking, why fluoridation? I get it. Back 75 years ago, they didn't have access to dental services, but a lot's improved over the years. We didn't have toothpaste the same way we do now, and it didn't have fluoride in it. Well, we still, these are data from today. We still see fluoridated communities have 25% less tooth decay. It's the single most effective intervention, especially at a population level, that we have in dentistry. I mentioned dentistry wasn't founded on population-based strategies, and it's really one of the few things we have that can affect total communities, and it crosses socioeconomic statuses, it crosses racial status, it basically crosses anything. I've got twins that are going into first grade at a very diverse elementary school. It's got 50% African American, it's got 30% white, it's got 20% Hispanic, 10% Asian. We have a very racial diverse group. They're all drinking the same drinking water there. And as long as they're not going out of district, as long as they're living in the city of Smyrna where I live, then even when they go to their homes, they're drinking the same level of fluoride in their drinking water. So it cross-cuts everything. And the other big thing is the benefits last a lifetime. And it really comes down to, again, why fluoridation? Because the science of it reducing tooth decay is just unquestionable. And so this is when I have to kind of go a little bit on the soapbox of oral health and the dental infrastructure and explain, why it's still a valuable, necessity and a wonderful public health intervention. The dental infrastructure for care, and I'm a dentist myself. I practice dentistry clinically. I work with a lot of dentists that they do wonderful care. But as you can imagine, if you think about it, historically, the dental infrastructure is very siloed. It's very fragmented. Imagine your own personal dentist. If you go to the dentist, it's kind of like how mom and pop medicine was 100 years ago. You go down to Dr. Jones, he's got a shingle hanging outside, and Dr. Jones does a great job for you if you happen to be a patient for Dr. Jones. But outside of that, dentists aren't really connected to any broader healthcare system. The electronic health records don't integrate with other electronic health records for, say, medical providers. So if you're not in the four walls of that brick and mortar system, you're kind of falling through the cracks and are kind of unknown. And this isn't honestly just me saying this. Even in 2011, the American Dental Association, they came out with a report and they referred to the oral health safety net as tattered. And so that's why it's so important to still have things like community water fluoridation in place across our country. This kind of reinforces what I said. This is from HRSA showing a dental health provider shortage area. Basically, purple is bad on this map for finding access to care. And I myself, I was part of the National Health Service Corps when I was working at FQHC in rural Georgia. I'm not sure how they come up with their numbers, but my site was designated as a 16, and the scale goes from 1 to 28, with higher numbers being worse access to care, less providers in the area. And there was only one other dentist in the entire county I was in, and I don't believe he was accepting new patients or might not have seen kids and didn't accept Medicaid and some insurances. And so I can only, and I was in a town of only 800 people. So I can only imagine what some of those higher health provider shortage areas indicate about availability to access. And so you still may be saying, okay, I get it. It's a need, it does good, but there's a lot more important things going on in the health and the health disparities and all sorts of other chronic diseases. This isn't a competition. I'm not there to say that we're number one and we're more important than anything else that we're facing in the medical community. But it is important to realize that certain things like tooth decay, which is also called caries or cavities, is the number one chronic disease of childhood. I don't think a lot of people realize that. It's about 5 times more common than even asthma. And it's always preventable. That's what's the most unfortunate part. And I do think it's important to consider it a chronic disease. A lot of times it isn't thought of like this, even in the dental community. To kind of oversimplify, somebody comes with a hole in the tooth, you clean the hole, you fill the hole, you solve the problem. Well, I tell people that's sort of like if somebody who has diabetes and has poor, vascularization and extremities, and unfortunately may have to have a toe amputated. It would be like saying, oh, I fixed your diabetes because I amputated the toe. You treated the downstream, after effects, but you didn't treat the underlying disease. And this is one of the challenges of thinking of dentistry is, drill and fill, thinking that treat once a problem arises. It's not much of a diagnosis, it's a treatment code, it's a procedure, instead of thinking about these early intervention strategies like community water fluoridation. And again, tooth decay, it's not just a hole in the tooth. It's not just even infection or pain, which would be enough. It leads to difficulty chewing, poor weight gain, nutritional issues. You can imagine the impact this has on a child in their early developmental ages. Difficulty concentrating, crooked teeth. It's actually one of the most common reasons that children have absenteeism from school. It's also a predictor of caries later in life. And like anything, when we wait for downstream problems, the treatment is more costly, more invasive, and doesn't necessarily improve outcomes in the long term. And I always, whenever I do a presentation, whether it's about community water fluoridation or really about anything, I encourage people when they think about dental decay to think beyond the mouth. Good oral health leads to better nutrition, social skills, employability. And on the flip side, things, kind of on the other side of the coin of that are poor focus, difficulty sleeping, speech issues, negative self-image, social isolation. These were things that I didn't just make these up or copy them off a website or something. I saw this firsthand working in that FQHC. I had patients that would come to me, this was pre-pandemic, but they would say, the only time I'd ever get out and see anybody in my community was going to church on Sundays. I haven't gone to church for the last 6 months because I'm so ashamed of my teeth. Or there'd be people that said, I'm afraid I'm going to lose my job. I'm afraid to talk to customers, or I'm a waitress and I don't like, smiling or talking to people. I had a patient one time that came in so much pain. I couldn't see him that day. He was an emergency. He just walked in. I gave him an antibiotic. I said, come back tomorrow morning and I'll extract that tooth for you. I worked him in. He did come back. Well, I found out later that he had gotten approval from his job to come off the first, to get off work the first day, but had not gotten approval to get off work the second day and was in so much pain he came back anyway. He ended up losing his job because of that. And so these, when it comes to oral health, there really are a lot of impacts beyond, just kind of a hole in the tooth or a cavity, when it comes to how it really impacts people. That's not just me saying this. This is a statement from our former Surgeon General, Jerome Adams, that oral health is essential to the general health and well-being of all Americans and can be achieved by all. However, many Americans continue to experience unnecessary pain and complications from poor oral health that adversely affect the well-being, adding substantial economic and social costs. Beyond that, we've learned a lot over the last 10, 20 years about an oral systemic connection. This was from the Academy of General Dentistry's monthly newsletter back in 2018 that noted that correlations between oral disease and systemic disease conditions are now broadly accepted by both dental and medical practitioners. 7 of the 10 leading causes of death reported by the Centers for Disease Control and Prevention can be connected to inflammation and/or bacteria in the oral cavity. Heart disease, cancer, chronic respiratory disease, stroke, Alzheimer's disease, diabetes, influenza, and pneumonia. Some of these, including the ones related to preterm birth, are more geared to gum disease. But it is interesting. Strep mutans is kind of the bad bacteria that is known for causing dental decay. It's been found in the atherosclerotic plaques upon autopsy of people with coronary heart disease. And it's also been found in the beta amyloid plaques in Alzheimer's patients upon autopsy after death. And so we know there's a connection here. We haven't figured out all the pathways of that connection, but we know that the mouth is connected to the rest of the body. And so it really is connected to a lot of significant chronic diseases in our society. Another thing I had not thought about was military readiness. I mentioned, back in 1945, we've certainly gotten better since then, right? Well, poor oral health also impacts our nation's ability to recruit young adults. It was noted by Colonel James Honey, the chief of the TRICARE dental care section, that historically dental readiness was the most problematic Department of Defense, Department of Defense individual medical readiness requirement. And even more recently today, service members have to go through a kind of a dental examination. And in 2008, 52% of new recruits in the U.S. Armed Forces were categorized as having oral health problems needing urgent attention, which would delay overseas deployment. A couple of years later, a senior official with the Department of Defense reaffirmed the DoD policy of fluoridating water supplies for all military bases, pointing out fluoridation will directly reduce the risk for dental decay and improve military readiness. And just as a public health issue, I know, just recently last year, CDC and their 10 Essentials of Public Health kind of infographic that was created years ago put equity at the kind of the heart of that. And so when we look at things like disparities, we see that 80% of decay is found in only a quarter of the children in a very narrow group between 5 and 17 years old. Approximately 1 in 4 children aged 3 to 9 living in poverty has untreated dental decay. We see these populations with increased risk or lower socioeconomic, has to do with level of parental education, little to any access to dental care, whether that's geographic or economic. Communities of color are also, unfortunately, like many other health indicators, higher risk for dental decay. So how does this work? Risk factors, we're not going to go into a whole lot of the etiology of this, but diets and sugars, carbohydrates, oral hygiene, whether you have dry mouth, bacterial levels. I have a little graphic here. The thing that just shows it a little bit better if it'll play here. So we'll try it. Basically shows how a tooth is built. On the outside of the tooth, we have enamel, which is made up of what's called hydroxyapatite. It's the hardest substance of the body. And hydroxyapatite is made up of calcium and phosphate ions. And in the mouth, we basically have an equilibrium in good times of kind of these ions. We have bacteria that kind of form in the mouth. They break down sugars, release acid, causes kind of a demineralization, dissociate some of those ions. But in a healthy mouth, we can have a remineralization process, which basically restores the enamel of that tooth. And the ions from the saliva go back and remineralize the teeth. What I like to describe this as is think of scaffolding, like painter scaffolding, whatever, on the side of the building. A lot of things I know say that can regrow enamel, rebuild enamel, and that's a lot of times just marketing. Basically, if you had 10 stories of scaffolding on the side of the building and you removed a couple of rods from the scaffolding, fluoride and even just natural buffering capacity of the mouth can remineralize that. If you were to whack off the top, 4 stories of a 10 stories of scaffolding, you cannot regrow that. And that's why it's important to catch things early. If they get really cavitated, where you can actually see, for lack of a better term, holes in teeth, even if something like traumatic happened to tooth and broke a tooth, you're not regrowing that. So it's important to catch these demineralizations early on. And how that works, the way fluoride strengthens that is basically when you have fluoride present in that kind of solution and that demineralization, remineralization activity in the mouth, the fluoride or ion replaces the hydroxyl ion and hydroxyapatite to create fluoroapatite. And this goes back way to my Gen Chem electronegativity days, but basically you have a stronger bond. It is less likely to break down in the presence of acid. It just creates a stronger matrix for the tooth. Now, early on, we thought this was mostly systemic in nature. Remember those trials, people that moved to the area back in Colorado Springs in the early 1900s, they didn't have the brown stain even once they started drinking the water. So it must only be if you're drinking it, as the teeth are in development. And there is a lot of evidence this will shows that there is a systemic benefit or pre-eruptive benefit to exposure to the optimal level of fluoride in drinking water. It is difficult to establish, to create causal pathways and take samples in utero of, fluoride levels and the histological preformation of teeth and things like that. But we do know that there is a systemic benefit. However, we've learned over the years there's also a topical benefit. There are other topical types of fluoride, like that you get when you go to the dentist, the fluoride varnishes, the old trays with the foam, and there is a perfect time and place for those. They're a wonderful intervention, but you're only getting them every 6 months. We've learned is actually just fluoride in drinking water when it's at that optimal level has a topical benefit. It's being there in the saliva as that demineralization, remineralization process is happening and maintaining a strong, enamel surface of the tooth and helping remineralize it when we have early demineralization, but it's not yet cavitated. We also are learning, at first it was like if it's only systemic in nature, it can only help kids as they're developing, but because it's topical in nature, it is helping adults throughout their lifetime. Ironically, because we've had fluoride and because we've had improved oral health care, people are keeping their teeth longer. They're not in dentures in high school anymore. They're keeping their teeth into their 60s and 70s. But because of that, we're learning they're more vulnerable to decay. Root surfaces may be exposed by receding gums. Many adults have dry mouth due to medications that cause dry mouth. They maybe have dexterity issues and are unable to have brushes thoroughly. And what we're seeing is fluoride even remineralizes the root surface of teeth. And so basically what we've learned is, and we've done so well, we've created almost a new problem that fortunately fluoride still helps, and that older adults are almost as susceptible or as susceptible to dental decay as young school children are. Back 50 years ago, they just wouldn't have teeth, so they wouldn't be susceptible to decay. Well, now we need to find things, which still includes community water fluoridation, to help protect those teeth. This is a graphic that kind of, goes to what I was saying about prevention being really a key. Yes, we can do fillings. Yes, we can do bigger fillings. Yes, we can do crowns. We can do root canals. We can do extractions. But this doesn't necessarily prevent future decay. And once you do a filling on a tooth, you are forever going to be challenged to probably replace that filling. A wonderfully done filling that lasts 30 years, still probably going to have to be replaced if done early enough in life. The bigger they get, which tends to happen, you may have to do a crown, you may have to get some to the nerve of the tooth, do a root canal. These are getting costlier and costlier as time goes on, and eventually leading to extraction of the tooth and an implant. And implants are wonderful, but we would really like to keep the natural tooth there because nothing is quite as good as the natural tooth. Water fluoridation is endorsed by many well-respected health organizations, public health organizations like the U.S. Public Health Service, American Waterworks Association, American Medical Association, American Dental Association, World Health Organization, American Academy of Pediatrics. There's a whole list of others that I can't begin to put on one slide, but some of the resources at the end of the presentation do have links to others. Our current Surgeon General, Dr. Murthy, who's the Surgeon General prior to Dr. Adams as well, it gave an endorsement back in 2015. Fluoride's effectiveness in preventing tooth decay extends throughout one's life. It has been endorsed by our Surgeon Generals throughout the ages ever since the trials started in 1945. Interestingly enough, not necessarily community water fluoridation, but oral health and why therefore community water fluoridation is important is still one of the priority areas for the Surgeon General. If you go to the Surgeon General priorities webpage, this was actually taken when Dr. Jerome Adams was still there, when there were 6. I literally just went there yesterday to see if it had been updated. I didn't know anything would be changed. Oral health is still there. I think maybe 1 is no longer there currently. Maybe health and national security is down to 5, but I did confirm oral health is still there. It still looks just like this. So still a very big national priority. And the CDC named water fluoridation as one of the 10 great public health achievements of the 20th century. A lot has been done with systemic kind of peer reviews in the year 2000, and then again in 2013, the U.S. Preventative Services Task Force did a very large a task force with subject matter experts that reviewed tons of literature, and they again confirmed, based on the evidence of effectiveness, the task force strongly recommended community water fluoridation in addition to school-based and school-length sealant programs. So we still have massive endorsement for a lot of these very well-respected, long historical scientific and health organizations. We have a new Healthy People 2030 objective. Fluoride has been included in all the Healthy Peoples going back to the initiation. And currently, for the ones that were just updated, the goal is to increase the proportion of U.S. population served by community water systems with optimally fluoridated water to about 77%. As of 2018, we were at 73%, and those are those who are on community water systems or public water systems. Obviously, there's a segment of the population that's on well water, and unfortunately, that's very hard to track and get data on, especially in aggregate. So when you're talking about the number of people that have access to fluoridated water in the country as a whole, it's closer to about 64%. Again, that's an estimate. We can really only kind of go off of with community water systems, public water systems. This is a map from Health Policy Institute from ADA. We have our state here because I live in Georgia, and we are proud to show off that we have 96% of Georgia's population that are on community water systems that have fluoridated water. You can see as we look around the country here, it ranges a lot. This is one of those things I took for granted. It's like, oh, drink tap water, it's got fluoride, good to go. There's probably laws around it. I honestly had that kind of laissez-faire attitude about it, and it wasn't until I got more in the population-based world that I started really researching and learning about it. As you see, a place like Hawaii is at 11%. Some places like Minnesota and Kentucky, 99, 100%. So the range is a lot more than I realized. I was trained to say basically to a patient, "Are you on a well? If so, we might need to worry about this. But if you're not on a well, no worries." Maybe it's because I have the benefit of being in Georgia, but I have a feeling that's probably true of other people in other states in their dental school education. One thing that can affect this and the rates is there are states that have legislative mandates, but it's not as many as I personally just would have thought. There's about 13 right now that have legislative mandates. And if I go to this next slide here, you can see they vary a lot by what the mandate says and how enforceable it is, and by year. Some of these go back, including Georgia. We were not the first, but pretty early, 1973. But we have some in the mid 60s here. Some as late as 2008, 1995. And what's interesting to me is if you look at the ones, it's not 100% true, but if you look at the ones that have early mandates, Kentucky, Minnesota, Georgia, Illinois, 1967, we see, go all the way to here, Minnesota, 99%, Illinois, 98%, Kentucky, 100%, Georgia, 96%. There are those with mandates that aren't as high, like Louisiana, which was only, but keep in mind, it was only 2008. California, only 1995. So yes, their rates are lower, but they haven't had as long for these mandates to kind of take effect. It's not like turning on a light switch and, a mandate comes out and just, there's a lot of logistics to actually implementing. There's also something that's been termed a halo effect. I kind of equate this to herd immunity when it comes to vaccinations. It's not to say that, if there's benefits, even if you're not in a fluoridated community, so we shouldn't care anymore. But if enough communities around you are fluoridated, you may be traveling to those communities. You may be buying products that use water from the community water systems in those communities. And getting indirect effects. And the more communities around you that have that, the more likely you are to get that halo effect. Kind of like, when we talk about herd immunity, even people that aren't vaccinated against something, if 90% of the population or 95% is, they have an indirect benefit. And so I look at that as a good thing. It's not an indication to say, hey, even if you're not fluoridated, you're fine. But it is an indication to say when vast areas and regions get fluoridated, it shares kind of the wealth and benefits. I thought it was important to talk about dental fluorosis because this is how it all started. This is, and not a good thing. But it's important to know the risk factors and really what it entails. It's basically just a change in the tooth's appearance. It's a cosmetic issue and very significant area, levels of fluoridation, well beyond the recommended guidelines. It can start to break down enamel. But the key is dental fluorosis is evident in the same percentage in areas with or without community water fluoridation. So this is, community water fluoridation systems are not contributing to this. It's very unlikely to happen when you are under 2 milligrams per liter, which is usually the guideline at the state level, from departments of environmental protection divisions, and even at the federal EPA. The threshold for this would be caused is much higher. The CDC has some examples of this. In the very severe area, this would be like that Colorado brown stain. But a lot of times you see it's much more mild. And I can tell you as a dentist, these top 3 up here, normal, questionable, very mild, you would have a lot of discrepancy in even the dental community. If you got 20 dentists, you might get 8 different diagnoses of whether this was nothing, whether this was fluorosis, whether this was actually early demineralization and a very early cavity forming. Once you get to this moderate area and you see it's uniform throughout the tooth, it's a little easier to diagnose. But these early stages are very subjective in how they come across. In fact, a lot of this isn't even in surveillance surveys and stuff documented anymore because of the subjectivity of it and hard to calibrate people that are screening. The main cause of dental fluorosis now is basically dental products and kids, for the most part, swallowing too much toothpaste. When we see those toothpaste ads, they put a giant swath, a big old S curve on the toothbrush, and that's my personal opinion. Is if you use that much toothpaste, you'll probably go through it faster and end up buying more toothpaste and buying more of their product. But you do not have a benefit with that much toothpaste. Basically, any adult or any older child over about 3 or 4 years old that can effectively spit on their own can just use an English pea size amount of toothpaste. Parents should supervise children under 6 years old. Like I said, I got 6-year-old twins. I still brush their teeth or let them brush it with some significant supervision every night. Make sure they spit. Children under 2, it's certainly infants, they're not going to be able to spit effectively. For that, we say use a smear or a rice grain size amount of fluoridated toothpaste on that toothbrush. And you can start brushing children's teeth with fluoridated toothpaste at a very early age. As soon as the first tooth erupts, basically, is when it's time to start brushing teeth. So whether that's basically newborn status, if they are very, early bloomers, or if they, don't have their first tooth erupt 1 year old, but when that first tooth erupts, you can start brushing teeth with a rice grain size amount of fluoridated toothpaste. They do make a reduced amount of level of fluoridated toothpaste and consider it like an infant or pediatric. The main reason that is because still people swallow toothpaste, use too much toothpaste. If you're using that amount, you can use whatever over-the-counter toothpaste. I went and walked into my bathroom. I started brushing my kids' teeth, got my own toothpaste, put it on the toothbrush, started brushing his teeth. They do recommend not using toothpaste over 1,100 parts per million, but you're not going to get that in the store with any regular toothpaste. That would become like prescription strength toothpaste that the dentist prescribes when you have very high risk of dental decay. And that is really, if we do that, if we use the right amount of toothpaste, then you will reduce fluorosis significantly. This is the famous picture of a grain of rice versus a pea. I know this seems silly, but very smart people gathered across the United States at work groups and task force. When they first used the word smear to describe what's on the left here, people didn't know what a smear was. They thought of taking a bagel out and putting a bunch of cream cheese on there. And it was like, well, that wasn't apparently good communication. So then they all got back together and they said, okay, we're going to say a grain of rice size. And if you were using that amount, grain of rice, for young children, infants up to about age 3 or 4 until they can effectively spit, and then going on to a English pea size of toothpaste from that age to 104, or as long as we can live, that is enough toothpaste for any other person on this earth. One thing to consider is bottled water. As a society, we've started drinking a lot more bottled water. There really isn't any kind of source to tell us if there's any fluoride in our bottled water, and a lot of times there isn't fluoride in our bottled water. So it's appropriate to assume that children whose only source of water is bottled are not receiving adequate amounts of fluoride in the bottled water. This is kind of the same as if you're being on a well, although it's important if you are on a well to at least have it tested, because like I said, well water can actually be higher than the recommended levels. That's not usually, if anything, it's usually lower, but without having a test, you don't really know. Another fun fact about bottled water that I didn't even realize until recently, tap water should be a neutral to even slightly basic pH, 7 to 7.2, something like that. We did a test just with some of our district staff one day with, I won't say product names, but or brand names, but with a variety of common brands of bottled water. And some had pHs as low as like 5.0, which is, like down to like soda levels. And so that's unrelated to fluoride, but just a little PSA for bottled water. Because of course the acid in any environment, no matter what it comes from, is contributing to breaking down of enamel as well. One thing to be aware of is, you may be thinking, I kind of took for granted community water fluoridation, and you may have taken for granted community water fluoridation. It's just this thing that's there and prevalent and we kind of forget about. And that seems to be true of the general population. There's been a couple of surveys done. One was done in Maryland. There was only 58% of Maryland residents can identify the purpose of adjusting fluoride in public drinking water. 80% of Americans admit they have very low level of knowledge about fluoridation. Another done in 2010 showed that, as far as very informed, only about 20%. And of course, we have to factor in things like response bias in that. I'm not exactly sure how that was carried out. But still to say, there's just very little awareness now. It's kind of gotten lost in the passages of time. So it is important. I didn't intend for this presentation to really be about how to talk to people that maybe have differing views or have read misleading information. And I don't necessarily want to go down that rabbit hole, which a lot of presentations are out there that can for you, and really focus on communication style. But I would just say, you take this knowledge of the importance of it, why it's still, a very effective population-based health approach that is one of the most cross-cutting across age, sex, race, orientation, anything. It exposes, if you're on that community water system or public water system, no matter who you are, how rich you are, what you look like, what you believe, you are receiving the same benefit. Talk positively about the benefits and just be proactive with it. I do have this one slide in here, mostly just because I didn't even know where to put it, but just you may hear about alternatives that are population-based approaches to community water fluoridation. But it's important to know that fluoridated water is the most common vehicle, impacting about 400 million people worldwide. It is predominant. The U.S. is by far the country that has done it the most comprehensively to the most people. There are other countries that actually use it by fluoridating salt. That's the second most common. This is a lot of Latin America, South America countries, as well as some of Europe. Some places have kind of experimented with fluoridating milk, sort of like fortified milk with vitamin D and things like that. And then, of course, we have things like fluoride supplements, drops, tablets. These were used more historically in the past when people were on well waters before we knew as much. they're still available, but they have to really be done in conjunction with, say, a pediatrician or your doctor, as well as a dentist. You have to kind of do an assessment of, okay, you're on a well. Did you get the well tested? What's that level? Where are you getting it from other sources? How much toothpaste are you using and things like that. So those are less common. So I'd like to go briefly into a little bit of the weeds. So I kind of talked about why it's important, broadly, generically what it is. How does this actually work in real life? Well, it works a little bit different in every state, and I try to talk more nationally, but the most knowledge I have is for Georgia and how it works in Georgia. We have about 315 to 330 adjusting water systems, community water systems that adjust fluoride in the state. And that's a lot of systems to try to keep up with and get data from. And these systems range from a big public water system serving half of Fulton County or Atlanta, Georgia, to systems that are so small they're serving like 50 maybe mobile homes and kind of a trailer park, and everything in between. And it's important to know that a lot of times, especially in these more rural areas, there's not a dedicated paid water plant operator, by title with specific training. A lot of times these are people from the local community. They could be anything from the town mayor to the person that's the maintenance person that's cutting the grass. And so we have to do our part as public health advocates and people kind of in this field to educate any way we can, to help out any way we can. We heavily rely on a group called the Georgia Rural Water Association. There's a state rural water association in each state. There may be different levels of engagement by, say, the state oral health program at the Department of Public Health or whatever public health agency there is. We have a wonderful relationship with the Georgia Rural Water Association, and there are boots on the ground. Fortunately, they believe in community water fluoridation. They're there to do a lot more than water fluoridation. They're ensuring safe drinking water, safe sewage water. They're helping local communities with their water systems and water plant operator education. But they're going out and evaluating every one of these 330 systems and giving us the evaluations. They're working with the operators to make sure they're educated, they have needing any technical assistance. If there's equipment they need, they have grants that can help supply equipment. And they are just absolutely vital to what we can do in our state. But what we do is I adopted some of these slides from my state fluoridation administrator to talk about that she actually gives as trainings to water plant operators. And so I edited them a little bit, but a lot of it is what the water plant operators would see when she does these 6 trainings a year. It used to be throughout the state when it was in person and we were traveling around. Now it's mostly virtual, but there's different types of forms. I know you can't read these, but basically they're just a spreadsheet. They're digital forms like the one on the left. There's hard copy paper forms that sometimes still get scanned in, where you're just recording a daily value and reading the fluoride levels. I think I have another one here that shows it. Again, I know this is way too small to read, but basically this shows all the months across the top, all the days of the months, 1 through 31 on the left, and a reading every day. We have a maximum read, we have an average read, we have a minimum read. We also have the level of natural fluoride in the water, because again, you have to have that before you know how much to add to get to that optimal level. And you can see, well, actually you probably can't see, I'm even having to squint a little bit here, but a lot of these are anywhere from 0.68 to 0.9. This is, and one over here is 1.03, barely over the recommended range. But I mentioned it's difficult to hit the nail on the head precisely. And this was a great example of a water system that was really doing a very good job of recording every day and documenting it and staying in that range. Another thing we do in Georgia is we do a split sample. This is only done once a month, but by the 10th of the month, they need every water plant in the state that adjusts fluoride needs to take a sample and split it up. They take their own reading, but they send it to a state lab that basically verifies that reading. And as long as it's then a kind of a range of discrepancy, that's fine. But that's just to make sure that we're reading things right, that it's just quality control. And I'm proud to say in Georgia, we do a great job of this. There's never really any issues. If they are, they're resolved very quickly. We are one of the states that have a legislative mandate to fluoridate that's been going on since 1973. There are some loopholes and the mandates are written differently. Like in Georgia, it does say as long as you have resources to buy equipment to say fluoridate. And they may not be aware of this, a local municipal water system, but like I said, the Georgia Water Association has funds available. They are wonderful at helping with this. Usually, equipment can be found. And so there are always going to be resources there, at least in the state that I know the most about, to start a fluoridation program if you are not already. The vast majority of, especially the larger municipal water systems are already fluoridating, and that's why we're at 96%. But we work with small systems all the time. We work with small systems that may be fluoridating but may not be reporting correctly. It's a real testament to Dixie Ann, my fluoridation administrator, who has built relationships with literally hundreds of people across the state that she had never met before until she just called them up one day and gave them some sweet Southern charm and got them to understand why it's important, educated them, and she has increased the rate of getting timely reports and complete reports, and really helping us understand the levels of optimal fluoridation going on in the state. And it should be noted, our mandate actually also is a little bit different in our range. It says, in the document, it says, I think we're still in the 0.7 to 1.2 and a target of 0.85. Again, very similar, but we're trying to basically preemptively kind of follow that new guideline and saying, if you're hitting 7, that's really the new gold standard. Try to hit an upper limit of 1.0 because that's the proposed range that will be the CDC guidance in a very formal fashion, hopefully very soon. And she really helps work with these individuals. Again, these aren't people necessarily that have chemistry degrees, or some honestly haven't graduated from high school. She helps them fill out the forms, what to put on there, things like if your form's not complete, tell me why. Make sure to put what the averages, the maximum, the minimum. She even breaks it down on how to take an average. And this is not meant to be condescending in any way or derogatory to these great men and women that are helping ensure this wonderful public health good. But it's simple things that they may not have signed up for this, had any training on this. There are trainings available, but they may be new, taking over. It may be a new role. And so, making sure we're getting accurate readings. And like I said, she's wonderful at reaching out to them, providing technical assistance. If they have any questions, making sure it's as simple for them as possible, even providing, forms or templates to use, things like that. Again, just kind of breaking it down, saying, if you didn't do a reading, if you forgot to one day, don't include that in your average. If you did read it and it was a 0, then that is a reading into including your average. Like simple things that can throw off, a reading or a report. Again, and in no way to be dismissive of their intelligence or anything like that. It's just, they step into a role they've never done before. It's mistakes any of us can make if we're not thinking about it. And so, having that support is very helpful. There is something called a community, water fluoridation quality award awarded out by the CDC. To do this, you have to report at least 21 days of the entire month period, and 19 of those days must be within that range. And you have to report 12 months, all 12 months out of the year. And so in Georgia, like I said, we have a very high percentage of our of all of our 330 adjusting systems that give these awards every year. It's almost impossible to ever, with at least that as many as we have, to get a perfect number. But we're very proud of the systems we have in Georgia. They take pride in it. They'll have these little awards hanging, on the walls of little small community buildings as you go into visits. So that's a testament to the CDC and showing appreciation for what these people do. This again, the sample of the little award here. I have a little bit about systems. This gets into the weeds. This is honestly more probably for the water plant operators, but it was interesting to me because, again, a dentist, but I had no idea how this worked kind of in the background. The main type of systems historically have been 3 different types. One called a dry feeder. I don't know how big this looks on your screen, but you can see it's like a bin. You'd see it something like a farmhouse or something for fertilizer or something. You throw dry a fluoride product, basically fluoride salt in there. It gets mixed in. You have fluorosilicic acid in large tanks. That's a liquid that's going in there. And then you have saturators, which also use a dry salt. And these things can be, they don't have to be in fancy places. They could be in what look like little, water pump houses and things like that. You still need to be doing, quality control and making sure things are clean. checked on, no pipes that are corroded, anything like that. Some of these products need PPE to be handled. In fact, they often do. And so, making safety precautions, safety glasses, gloves, those kind of things when handling these products in very high concentrations. Again, they're getting diluted down to that optimal range, but they start in very high concentrations. And so again, Georgia Water Association and the wonderful work they do, they help train, they help make sure that people are following these safety precautions and guidelines and that people are informed. Again, these types of additives, fluorosilicic acid is the one that goes into that large tank. It's the most commonly used. It's water-based. It's about 80% of systems, community water systems in the United States. Sodium fluorosilicate is a dry salt additive. It's the second most used at about 13%, and it's usually used in those dry feeder systems. And sodium fluoride is also a dry salt additive, slightly different structure. It's typically used in the smallest water systems. It's dissolved in a solution for being added to water. Only about 7% of the total U.S. population is served by this. It's used in the saturator systems typically, but can be used in dry feeder systems. One thing that's super exciting, if I'd have given you this presentation a year ago, I don't think I'd have these slides. But we have a new system here that had just emerged this year. It's been in the works and piloted for several years. It's made by Casey Industries. And again, I have no connection to them. They're just the ones that make it. It's called a New Wave Fluoride Technology or New Wave Fluoridation System. And what it does is it has these long kind of chambers that you can drop basically the little pellets. They look like chlorine pellets that you put in a pool. They're about the size of a hockey puck. They have a constant diffusion rate based on water flow through them. So it's very easy very easy to have any kind of user error, operational error. It's going to maintain a constant passive kind of diffusion, dissolving of the tablet based on water flow, and create that optimal level. And when the tank starts getting low and your tablets are starting getting low, you take more, you open the top of the tank, you throw them in, and you keep going. And so these are very low cost, very low, overhead and time. They're perfect for rural systems that, especially small ones that maybe serve less than it can serve up to 10,000, kind of on average is the estimate, communities, or population size communities, but also perfect for much smaller ones too, that may not have, the resources. These are just a few $1,000s to install. And we're really hoping that these will become the future and provide a lot of support to rural communities. We're proud to say that this was one of the pilots for this, where it was being tested, was in Cleveland, Georgia. And I'm personally hopeful that it was already in place, but of course, as a pilot, it isn't a permanent fixture. It has to go through some other rounds of approval before it becomes a permanent fixture. So I'm hoping that Georgia will become the first state to actually have one of these as a permanent community water fluoridation piece of equipment. I think several other states are right there neck and neck with us that might get it in sooner, but we're very excited. And this was a big deal. This was something even the CDC as a whole had a press release in March of this year talking about this could offer access to optimally fluoridated water for up to 19 million people in the US for the first time. Again, it's designed to dissolve in small amounts of water, much like a chlorine tablet used in the swimming pool. It could allow nearly 32,000 small public utilities, often in underserved rural areas, to contribute to the National Healthy People goal of providing access to fluoridated water up to 77.1% by the year 2030. And this, not to drop names, I mean, you probably know the people that are kind of high up in the CDC, but we even have a quote by Dr. Karen Hacker, director of the CDC's National Center for Chronic Disease Prevention and Health Promotion, in this press release, where she says drinking fluoridated water keeps strong teeth and reduces cavities, resulting in less pain, fewer fillings, and teeth pulled, and fewer missed days of work and school. As we honor World Oral Health Day, which was back in March, I am proud we can, for the first time, make available an important prevention strategy to so many people. Another thing the CDC is offering is a new platform that was developed over the last couple of years. In fact, I think it just went live maybe 2019 or 2020, called Flow, Fluoridation Learning Online. It's a very robust, comprehensive training system. It can be taken by oral health people like dentists like me, but it's also intended for water plant operators. It's got a little bit of everything. It's got the oral health side and why it benefits teeth. It's got things about the equipment and saturators and feeders, and basically everything in between. I know they were working to try to get kind of accreditation for CEs for water plant operators. I'm not sure what status is that yet. I think some states and their state level Rural Water Association is trying to get certified at a state level to say this is basically can be certified for CEs, for water plant operators, because water plant operators do have to get a number of CEs every year for credentialing. As far as other resources, I mean, really CDC has a wonderful website. I mean, everything you can imagine, you know, the benefits page, a lot I've talked about, safety, tons of historical documents and peer-reviewed journal articles about the safety, some little stuff about like other fluoridation products and fluoride delivery systems, guidelines and recommendations, things on the optimal range, the history of the optimal range, statistics that come from the National Health Surveillance System. It's interesting, there's not a publicly facing site, but there is a site called Wafers where the information gets sent to state fluoridation administrators, then gets entered into a CDC database, which stands for Water Fluoridation Reporting System. So that's how we kind of get national level data. It trickles up from the states. That data actually does get put on something called My Water's Fluoride, as you see the first link here. That's also through CDC, but it's a really cool link where you can go to and type in, you know, the county you live in or your address and find out, you know, what is your water system that's serving you, the level of fluoride, the type of system, whether your purchase subsidies and municipalities actually purchase their water from a neighboring county or neighboring system. So you can find out then if that water is fluoridated and what fluoridation level is. American Fluoridation Society is another wonderful, wonderful resource. They're relatively new on the scene compared to some of these other groups. I want to say maybe in the last 10, 15 years. But there are a lot of former dentists, pediatric dentists, people that have worked in academic institutions, and really are super passionate about this. They have a little more flexibility than say maybe governmental organizations as far as advocacy, but they're wonderful at educating. They have a wonderful repository of resources, you know, everything you could imagine on scientific literature showing the safety and efficacy of fluoridation systems. Campaign for Dental Health, which is ILikeMyTeeth.org, has again wonderful information on fluoridation. Of course, the American Dental Association does, and the American Academy of Pediatrics. I wanted to end with one fun fact for the day. I had to be something bold that you would remember. And so I just find this just crazy when you think about, you know, when we talk about different types of cost savings and impact, the CDC notes that this is every year annually, optimally fluoridating water across US communities saves $6.5 billion in dental treatment costs. That correlates to that average of about $20 and save dental treatment costs for every dollar spent on community water fluoridation, which is just a staggering number to me. When I think of dentistry is usually the small fish in the big pond, and so we don't have big numbers like that when it comes to whether it's Medicaid or Medicare or cost of services. But that one, it still shocks me every time I see it, and it's just an amazing number. So summary, you know, basically, even though this has been around a long time, it is important to not kind of, you know, put it on the back burner, you take it for granted, be complacent around it, because it still is one of the most effective prevention strategies for reducing dental decay and enamel and root caries. It affects all age groups. This isn't just children. It does have a major impact on children, but it goes all the way up through senior citizens, older adults. It's one of the most amazing, equitable population-based health interventions personally that I can ever think of. And we have very few population-based interventions, period, in the world of dentistry. A lot of dentistry is still patient, individual kind of care. We have things like sealant programs that are, you know, getting into that population kind of approach, but there are very few things that are equitable across many demographics as something like water fluoridation. I think that's one of the reasons it was listed by CDC as one of the top 10 public health achievements in the 20th century. Its benefits, even like I said, that halo effect, it has impact beyond even communities that have it as part of within their community, and a lot of adjacent communities do. It has that economic cost savings, and we have 75 years of quality research in support of the clinical benefits and safety. So with that, I love this quote by Kip Duchan, who's recently retired. He was a previous national fluoridation engineer with CDC, and winner of the Jeffrey P. Copeland Award, which I believe is the highest honor a CDC employee can receive, where he noted that water plant operators in the U.S. do more to reduce dental decay than all the dentists in the country. And I kind of have a little tongue-in-cheek response, feeling with Kip about this. But I mean, in truth, as a dentist, I can't deny it. I've gone to trainings for water plant operators, and I stood up and said, you all are so important. You're doing more than I could ever do as an individual dental provider because of just the number of people you reach in your community and the impact you have on your community. And oftentimes those water plant operators are members of those same communities. And so I think it's important to show our appreciation. That's why I always like to thank the Water Plant Operators of America. I like myteeth.org has their own little thing for water plant operators. And just saying thank you. And with that, I'll wrap it up by saying thanks to all of you for sticking with me this time. This is my favorite quote from Mr. Rogers. And whether we're talking about water fluoridation or other public health interventions, I know all of you are part of the good fight and fighting in your own respective fields. And so when we deal with stuff, tough stuff like we did in the past year and just in ongoing, you all are the inspiration I find they're out there doing just amazing work. And so with that, I'll stop and see if there's any questions.
So this presentation, thank you, Dr. Barefoot. This presentation is now open for questions. You can type your questions into the chat and Dr. Barefoot will get to them in a minute. The first question was about actually the preventive medicine residency program and fellowship. So I'll just address that question first. And there was a question about the applications for CDC's preventive medicine residency and fellowship. And the class of 2022's application window is now open through August 31st. If you or know someone who is a physician, a dentist, a veterinarian, nurse, or other allied health professional who wants to apply to the CDC's preventive medicine residency and fellowship, it's since 1972, the PMRF has developed a public health leaders skilled in program evaluation, management, policy, and population health improvement. And the PMRF experiences strengthen participants' ability to bridge medicine and public health and preparing graduates for leadership roles at domestic and global levels. And you can apply online at www.cdc.gov/prevmed. But any other questions, you can put them in the chat for Dr. Barefoot.
Yes, there was one question about level of fluorosis and children. And what I would say is, even as a dentist, it's very difficult to get people calibrated, especially those lower levels, on what constitute fluorosis. In fact, some of the surveillance guidelines for some of the national surveys have actually dropped that because like I said, a lot of dentists might identify it. It's very subjective in it, especially on those very low levels of mild and very mild. What we do have is significant 75 years of study to show that we do not see significant levels of fluorosis when we are under 2 parts per million or 2 milligrams per liter as the level of fluoride in drinking water. So again, what we're really talking about here is adjusting to an optimal level. Like I said, I mean, there are areas where a natural well might be higher than that. It's actually very difficult to get fluoride out of water. You may wonder, like things like filtration, like your carbon-based filters, your Brita filters, that doesn't take it out. You have to have something called reverse osmosis. Is the only way I know of to actually get it out of the water. And a lot of times, say you have a natural well where it's too high, it's actually cheaper to just dig a separate well than to try to install some of that equipment. And so, that's what I would defer to is just understanding, where, what was the water levels, where was the samples taken from, but there's just been so much over time reviewed and peer-reviewed journal articles. The United States Preventative U.S. Preventative Task Force, American Dental Association, like I said, CDC, that really seems like that 2 milligrams per liter is really the threshold. And that's why we have a maximum range at half of that. We even going back to 1945, we were not seeing fluorosis at that level. There was a question about if you happen to live in a state or area that doesn't have fluoridation, how should adults gain access to fluoride to support dental and bone health later in life? I wonder what the social determinants of health are for individuals who have a lifetime of low absent fluoride intake. I mean, we have long longitudinal studies to show people that grew up without it or at low levels, wells that were documented as having low levels, just do have higher rates of dental decay. Like I said, there are other methods of getting it, but unfortunately, it's not to the degree of just kind of a everyday present method. I would first say you would want to test, you want to like go to My Water's fluoride and find out how much is in the drinking water. Maybe there's a natural level, and then talk to your dentist or dental provider. Depending on age, depending on other factors, depending on what we call a caries risk assessment, how at risk are you? You might need a prescription strength dose toothpaste like Prevenant 5000 or something like that. And there are, like I said, there are fortified salts and things like that, but typically they're going to be hard to find in the United States. You're going to find those more in other countries. And then, I mean, there's always debates. I'm not here to talk about legislation or lobbying or anything like that, but those conversations do happen with other advocacy groups at local levels. Reaching out to your state dental association, your state dental hygienist association, they may have information of any kind of local level things that are going on around that. There was a question about over-the-counter whiteners. That really doesn't have to do anything to do with, it's not how to impact the fluoride discussion. There hasn't been a long-term studies on some of these, and it very much depends on how much you're doing it. It's very kind of dose dependent. Usually what happens with the whiteners is you're using things that are either hydrogen peroxide or breaking down to carbamide peroxide. They break carbon-carbon double bonds in the tooth, and that's what kind of clears up staining. But they're first of all, they're only going to work on kind of natural stain. If you have internalized stain, they're not going to work as well. It's for people that drink a lot of coffee, red wine, things like that. It tends to, if you're a chronic user and use it over long periods of time, it can almost make the enamel translucent. It's prone to causing sensitivity. It's not likely to happen, with just occasional use or things like that. But I would say I don't think there's any studies that have, really looked at like randomized controlled trials of people that are taking a very high dosage of whitening, and you have two groups that are both doing that, looking at one that's drinking fluoridated water and one that's not, and seeing it as making up for any kind of desensitization or anything like that. I would say for the most part, it's not really related to the fluoridation discussion. There's a question: what is the background on recent opposition to community fluoridation? Can you talk about why we need so many prominent statements of support, Surgeon General, AAP, et cetera, for something that seems like such an obvious public health win? I tend to agree, but it kind of goes back to my original statement of, I think, and I'm guilty of this too, I think we got kind of complacent. I mean, when I graduated dental school, I just thought, hey, sure, yeah, if you're on a well, you might be in trouble, but if otherwise you're getting optimally fluoridated water. At the time I was in dental school, I think it was the target said was 1 part per million. That was what I was, and so I just assumed, I didn't know any of this. I assumed, if you're on public drinking water anywhere in the whole country, you're probably getting 1 parts per million. I should just encourage people to drink, from tap water. And so there's a little bit of probably we've forgotten it over the years of why it's important, and just kind of, gotten lost in the shuffle. I think there's a lot, like I said, that parallels immunizations and vaccines and need for education, improved literacy around it, understanding hesitancy and how to effectively communicate with potentially hesitant groups in a culturally competent in an effective way, so we're not getting in arguments. You know, I don't think anybody is, you know, achieving success by, you know, going back and forth and arguing with people on Facebook feeds and things like that. So I think we need to have a real conversation about communication and effective communication and making sure people are informed. You know, it does have weight when it comes from places like the Surgeon General or American Academy of Pediatrics or ADA. And I'm personally very grateful for those statements, but even that, you know, I didn't know until about a year ago that the Surgeon General, and this is before COVID, but that oral health is one of his top 6 priorities. And I'm a dentist. You know, I don't know, especially in government agencies and public agencies, historically, we haven't been, you know, we're not hiring the best, you know, marketers in the country because it hasn't really felt like a role for us to sell these things. I think that's just kind of the nature of who we are. I think selling may be a bad word, but you know, effective communication of your message has become a more important aspect of public health. Nothing more exemplary than this past year. You know, we have all these campaigns and social media campaigns and things about, you know, immunization and the vaccination and COVID-19. Those are relatively brave new worlds when it comes to how to communicate those things. And so I think, to your point, why do we need statements from these groups? It's not just that we need statements, we need to make sure that people are hearing those statements and the right people are hearing those statements and there's trust built in these systems. Someone mentioned the question about like Brita systems. Those carbon-based systems aren't going to remove fluoride. So if you are drinking from your tap, but filling up a Brita, that's fine. Like I said, the main type that I'm aware of is called a reverse osmosis system. And you're not going to have one of those on by accident without really knowing it. There's a question about the national fluoridation level was lowered a few years ago. Like I said, it's considered a proposed range. That did happen a few years ago. I don't believe it's been gone through all the approvals, at least the CDC range. I think like anything with any kind of health intervention, or, you know, you're doing the least to get the most. For a multitude of reasons. You know, you're really looking at data over decades and decades and decades and seeing, you know, where are we seeing that most efficient threshold, the maximum benefit for the minimum intervention. You know, from a cost perspective, from a clinical perspective, we know that at around from 0 up to 0.6 milligrams per liter, we see almost an exponential benefit. And then we see a little bit of a tapering, but still benefit from about 0.6 to 1, and then it leveling off and not seeing nearly as much benefit after it levels higher than 1.0. And then we start seeing things like fluorosis happening at twice that level at 2.0. And so I think that just comes down to what's the most we can do, you know, with the least involved, which is you know, a tenet of kind of healthcare in general, I think. There's a question here about if, can you comment on the whole house water filtration and do those filter fluoride or not? Is there a way to add fluoride separately if they do not, if you're talking about, the question says, do those filter fluoride or not? Is there a way to add fluoride separately if they do not filter? I would interpret filter as filtering it out. And like I said, that would be the only one I'm aware of is reverse osmosis systems, which are getting quite costly. As far as adding it, I'm not aware of any way to add it at the home level into, or residential level into the water supply. If you aren't getting it, if you're on a well or if you're in a non-fluoridated community, you're probably going to have to, look at all the dietary things you get and where you get water. Are you getting it from, are you getting exposure to other communities, or are you, buying a cup of coffee in the county next door every single morning and getting it? But mostly it would just be to talk to your dental provider and say you're concerned about this, have them do a carious risk assessment, talk to them about, like I said, there are still supplements, drops, that it can be taken, but it is very kind of independent depending on the situation. There's somebody that said, do you have a mandatory law change in Georgia where your target is 8.5? Do you follow the federal recommendations to be at 7.7? Fortunately, this 0.7 target is in our range. So we're not doing anything outside of our range. We, basically if they're in that, in the range, we are, and again, we just have recommendations too. We provide all the information and say what the legislative mandate says. We say what the updated guidelines say. We are not a regulatory agency and enforce, and we cannot force things from like CDC. We just educate and provide guidelines, and try to work with them to kind of stay around there. If we're, and a lot of times, like I said, these are not hitting the nail on the head. They may be anywhere from 0.58 one day to 1.1. They may be, or hitting, 0.65 to 0.85. And so it's not a moot point, but it's, you're really splitting hairs when they're just kind of bouncing around in that range anyway. And so we just encourage people, to make sure they're reporting, make sure they're taking tests every day, try to ask if they have, we try to be we're not a disciplinarian there. We're not there to yell at them for not, doing a good enough job. We're really there to provide technical assistance and education and try to provide resources wherever they can to make sure they're as close to that range as possible. My fellow colleague Howard asked about some, we're hearing things about anti-fluoridation activism and how public health professionals can best respond to criticisms of water fluoridation programs. There's a whole psychology behind that. I'm not a communications expert. I think with anything, yelling and fighting and raising our fist in the air is no matter what the topic is not going to build bridges or help us come to consensuses. I think, just sharing resources, sharing some of the resources I have that can lead to a lot of peer-reviewed journal articles over the last 75 years. Well-respected groups like American Academy of Pediatrics, American Dental Association. What I think works the best is if there is a local community, because that's usually what it is. It's a local community where there may be a growing group that has concerns, and maybe it's just they've had misinformation or there's a lack of awareness, which is perfectly understandable. If local champions in the area work to educate, that seems to be more effective. If some person that someone's never met sends them an article from some organization they've never heard of or don't really know anything about, again, this is just my own personal feelings now. I don't think that has the same impact as if the dentist that you've gone to your whole life and taken your child to and trust says, I believe in community water fluoridation. I've read all the literature and the safety and efficacy of it. I'm drinking the same water as you. My children are drinking the same water as you. Same thing with, your family physician, your pediatrician. people in local community groups. That just from stories I've heard, because I'm not out there lobbying or advocating, I have to, a fine line I have to walk with that. I'm just there to educate. But if there are those people that are coming in local communities, it seems to have a very positive impact.
Thank you, Dr. Barefoot. Due to the time, that'll be the last question, even though there's plenty of comments and questions for you today. We thank you for the presentation and the question and answer period. Please join us for our next Preventive Medicine Grand Rounds, which will be held on Wednesday, August 4th at 1:30 to 3 p.m. Eastern Daylight Time. Thank you, everyone, for your attendance, and thank you, Dr. Barefoot.
Thank you.